Yeah, Priscilla, he is a little busy, I believe.
Okay.
Customer
Yeah.
introduction.
Okay. Um,
And our treasurer,
Shobha, madam, no
Dr.
problem.
Shobha Bembalgi, has also joined. Hello, Shobha. And
Hi,
our
madam. Hi.
president-elect, Dr. Rajashri Palladi, has also joined.
Namaste.
Yeah.
Welcome, Dr. Rajeshwari, madam, and Shobha, ma'am, Shobha Bembalgi, ma'am. I now request Dr. Shobha Gudi, ma'am, to please give the address.
Not so much as address. I would just like to welcome everybody to Kasoga. And I compliment Prabha yet again for her excellent, perseverance for transferring knowledge and skill to our Kasogians through her webinars. And I'm particularly excited today because she has coined it as laparoscopic hysterectomy from safety to surgical excellence. And I think it is so like Prabha to say something so positive and wanting to teach everyone and bringing in the best of speakers, Dr. GSS Mohapatra and Dr. Egbert Saldana, who are real experts in the subject. And also, you're going to bring in the case perspective along with Santosh Rathor. And you have an array of chairpersons also. Parimala and Sri Prada, both of them will do full justice to the session. So, welcome all faculty to Kasoga, and thank you, Prabha, for organizing this. And over to you.
Thank you, ma'am. Thank you. I really appreciate Shobha Gudi, madam. All my webinars, madam has encouraged, and she has attended all my webinars till now and given us a support so
And
well.
Prabha, you told me that, ma'am, you won't stay full, but today I'm determined to stay because this is something
Thank you.
which is
Thank you.
all of us wish to learn this well. So, thank you very much. Thank you. Yeah.
Thank you,
Yes.
Shobha, ma'am. Let's begin with our academic sessions. We have the first talk. I request Dr. Parimala Devi, madam, to please chair the session. Um, Dr. Parimala Devi, ma'am, is a highly esteemed gynecologist and obstetrician with a career of 42 years. She has a wide variety of interests, including hysteroscopy, infertility, and hysterectomy. Madam has done her UG from KIMS in 82, followed by her post graduation. She's received a special training FICS in UK and FICOG also. She's been honored with the prestigious awards such as the Aryabhatta Award, Mother Teresa Award, and a gold medal for active management of septic abortion by the Rotary Club of Bangalore in 1998. She holds the membership in BSOG and the Karnataka Medical Council. On behalf of Endoscopic Committee, we welcome you, Parimala ma'am, and request you to please take over the session. The first session is by Dr. GSS Mohapatra sir on step-by-step safe laparoscopic hysterectomy, the tips, tricks, and energy use. Over to you, Parimala ma'am.
Thank you, Priscilla, and I am really very much privileged to be here with Dr. Shobha Gudi and Dr. Prabha Desai's lead today in this webinar. And I would like to say my gratitude to all the people in the KSOG and KCOG for having given this opportunity. Maybe it is a webinar, but there is so much of information which we take and go from these sessions. And Shobha has been wonderfully being here, trying to put lot of information. And my role as a chairperson to introduce Dr. Mohapatra is he is endometriosis expert and excision specialist, I can say. He is the director of advanced gynec laparoscopy and endometriosis, Ankura Hospital for Women and Children, Bhubaneswar. Visiting consultant to Apollo and also ex-HOD of Manipal. And also he is MD in obstetrics and gynecology from Odisha. And he is a the first gynec robotic surgeon. Am I right, Jesus Mahapatra?
Yes.
And in Odisha's first, as many firsts are there in his credit actually. And we note surgeon also. And Odisha is his first microablation expert and trained in advanced endometriosis in France, Germany, and Italy. I think these days of a lot of technological advancement up to robotic and now the AI being the scene, it's like very much like wanting, like demanding to know where exactly we should go rightly and we should take care. So with this, I would like to thank everyone and welcome Mahapatra for his deliberation today. Thank you.
Thank you, ma'am. It's a pleasure. Hope I'm audible.
Yes, yes.
Yes, sir.
Yes. So,
Audible, audible.
thanks Kesoga and thanks Prabha in
Yes,
special
sir.
for
Yes.
inviting me to speak on this topic. Very close to my heart. I would just wanted to start by saying that this is targeted towards the people who are beginners, who are finding it difficult to struggle. This is not targeted towards the pioneers already whom Karnataka has produced a lot. This is specifically for people who want to grow, people who want to learn basic endoscopy. Because when I was young, maybe 15, 20 years back, I used to go to conferences and I used to find it very difficult that I was mesmerized by the surgeries, but I was finding it very difficult to come back motivated because I used to see those surgeries being done with big gadgets like Thunderbeat, Ligasure, Harmonic. So today's will be an all and out, all and all, and it will be a practical topic. I will not be speaking a lot on theory. I'll be showing you a lot of videos, and it will be divided into two parts. The first part, how I routinely do my TLH, and secondly, is TLH in difficult situations. So the tips, the tricks, and so let me begin by sharing my screen. Um, is it visible, Prabha?
Yes,
Hello?
it's visible. Visible, Mahapatra. Yes,
Okay,
yes.
thank you. Oh, yeah.
Step by
So I
step
begin.
laparoscopy. Visible.
Yeah,
Yeah.
yeah, thank you. So she has given me such a short topic that I have to cover the whole of TLH. And today, when we are speaking of lap hysterectomy, it is going to be total laparoscopic hysterectomy specifically. And I've been asked to speak on tips, tricks, and energy sources. So it is going to be so short that I will find the audience in this in this situation if I continue to speak for hours together. So I'll be very crisp and brisk as well. So everyone has their own style. Shahrukh, Kritik, everyone. So every TLH, every surgeon who does a TLH has his or her own style. So in laparoscopy, the first thing is that we can design our own step after following many people. We can select one step each from one surgeon and finally design our own. So every style is unique. Every style is to be respected. There is no one particular way of doing a TLH. So let us begin with the bowel preparation. In the bowel preparation, we ask our patients to be on a liquid diet 24 hours prior to the surgery and just the night before we give them 2 tablets of Dulcolax. That is the only bowel preparation that we require for a routine simple TLH. I'm not talking of endometriosis cases where we require to do a bowel resection. We need a good team. You know, the anesthetist, the sister, the person, everyone should be understanding the role of each person. If the anesthetist is not happy with you, if you have not given him or her a good cup of coffee in the morning, then you will not get your desired head low to do a good surgery. Now, how low is good head low? Is the table going to hit the bottom of the ground it's going to hit the floor like a seesaw? No. The level at which the bowel starts to fall down from the pelvis is going to be the point where you know that this is your adequate good head low, and that is roughly 15-degree Trendelenburg. A special mention about Allen stirrups. They are of wonderful use in a surgery because they help you to position the patient well and they provide stable leg support with controlled hip flexion for long surgeries. In between surgeries, you can move the legs. So Allen stirrups need special mention in today's advanced technology scenario. So this is how an Allen stirrup is placed. This is how the legs are positioned, flat, absolutely flat at the level of the tummy, abducted, and this is how the position of the leg should be in a routine TLH. What about the vision? Should you have a single chip, 3 chip, 2D, 3D, 4K? If you can afford a 3D, 4K, wonderful. But the bare minimum is a good HD vision at least. Gone are the days when you should be doing your surgeries with a single chip or a 3 chip camera. The bare minimum for doing a routine TLH is at least a good HD vision. Port placement. Normally, our port, we place one 10 mm port, 2 to 3 fingers above the umbilicus, and 3 ports, which are secondary ports, 5 mm ports. Out of them, 2 are ipsilateral. One is 2 centimeter above and 1 centimeter medial to the anterior superior iliac spine. And the other will be making an obtuse angle with it at the level of the umbilicus. And the third trocar will be on the contralateral side at exactly a mirror image of the first trocar. The most important game changer in doing a good surgery will always be a traction and good counter traction. So if the traction and counter traction between the 2 persons in the team is not the same, then the surgery is going to be inadequate or difficult. Both of them are going to struggle. So what do you need? Do you need a uterine manipulator? Do you need a myma screw or nothing? So we routinely use the Mehul Sukhadia manipulator, which is a very simple manipulator, which I'll be showing you just now. In big fibroids, we use the myma screw. And when we are not able to insert anything, then we can do it just with a routine needle holder and a shearer. So no particular technique is going to be mandatory. You can change your technique based on the requirement of the case. This is the routine manipulator which we use. It is a simple tube, vaginal tube, a long rod with a tip. We measure the tip of the uterine length, and based on the uterine length, we decide which length to be taken. It is tied to the tip of the cervix, and at the vaginal end, we have a person holding the manipulator. The advantage of using a vaginal manipulator is two. One, it is very useful for people who are learning endoscopy, so that they can in difficult situations, they can just push the tube up and they will be able to appreciate the vault when they want to cut it. And secondly, when you use a myma screw, you block one of the ports. So if you're not using a myma screw, you are using a vaginal tube manipulator from below, you have one more extra port to work with. So which energy source? Should be using a ligature or a thunderbeat or a harmonic? We'll come to it. Remember, you don't need any fancy gadgets to do a good routine hysterectomy. In fact, difficult hysterectomies, I do all my endometriotic surgeries with a routine shearer. I don't use the harmonic. I don't use the ligature. I don't need any fancy gadgets to do a good difficult surgery as well. So this is the difference between the harmonic scalpel and ligature. We'll be coming to it a bit later. But the thing that I'm very proud of or very happy using is the great Indian Jugaad, the bipolar shearer. This is a wonderful instrument which helps me to do all the surgeries very well. It is fast, it is brisk. You can just hold the tip with the tip and cut. You can coagulate, you can cut, and it has a learning curve. And once you master it, then it is the best instrument to work with. So I'll run through the theory very fast. How do? I begin with the sigmoid flip. Always begin the surgery from the pelvis at the level of the sigmoid colon. You flip it. Start from the left-sided cornuals. Move on to the bladder, the UV fold. Now, a very important tip when you're doing a bladder dissection: lift the whole bladder. Don't lift up only the peritoneum and push it beyond the tube. And it should be at least 1 centimeter more than what you feel is sufficient. Suppose you feel that this much of dissection is sufficient, then dissect 1 centimeter more so that you have enough tissue to suture when you're doing it. And you should repeat the steps on the other side. Opening of the vault. Gone are the days then when we were using monopolar to cut the vault. There are many people who use the harmonic. I use the harmonic also. You can cut it open with a shearer as well. Closure of vault. It can be done by Vicryl, it can be done by Rapid, it can be done by barb sutures, V-locks, Stratafix, and it is personal choice. People use number 1, 1O, or even 2O. Is ureterolysis a must? Now, just because you have a hammer in your hand, it doesn't mean that every problem should appear like a nail. So, except in endometriosis or in a case of large cervical fibroid, I don't think it is mandatory to do a ureterolysis for any routine TLH. So, this is how I'm showing you our technique. Beginning on the left side uteroovarian ligament and fallopian tube being taken by the shearer. Now comes the round ligament. There is no mandatory rule whether you should be taking the round ligament first or the fallopian tube. You can take anything that comes your way. And as you complete the cornuals into the bladder, you see, just be very superficial, don't go deep. In one hand, you can be lifting the peritoneum, the UV fold, and in the other, the champagne effect. Can you see the bubbles? In the bladder dissection, those champagne effect, the bubbles are going to be your friend. In laparoscopy, gas is your best friend. Now the posterior peritoneum, we have to do it so that the ureter falls away. Now the left uterine. See, once the UV fold has been dissected and the posterior fold has been dissected, uterine. In some time, you will see the uterine lumen gone. Now, again, after that, you will dissect the paracervical tissue and do the posterior dissection till the opposite uterosacral ligament. Don't go beyond that. Otherwise, you might injure the ureter. And now, it is an intrafascial hysterectomy. So, now on the other side, you stop there. Now come to the other side cornuals. You can coagulate with a bipolar and then cut with a shearer. But if you are experienced enough, you can directly coagulate and cut with a shearer as well. So this is a step which I was showing to my fellow. My fellow was cutting it with a shearer, and I was coagulating it for her with a bipolar. So I included this to show that you can use two energy sources as well as do it even with one. At the beginning of your career, it is wise that you use one energy source at a time. And as you experience, as you mature, you can use two energy. One bipolar, on the other hand, shearer, or on one hand bipolar, and the other hand, you can use a harmonic scalpel. Now the round ligament being taken. There are many cases when you may not start from the left side. You should be an opportunistic surgeon. Suppose you see that there is more space on the right and there is less space on the left. You can begin from the right and go and dissect the UV fold as well. Now the shearer we are making small busts. You see, these are small busts and the UV fold dissected. Now the right side posterior fold, right uterine being taken by my fellow. And wait for the bubbles to stop. It should be slow cooking. You cannot cook it very fast. It should be very slow. And once that is done, begin your dissection with your shearer once again. The right side uterine lumen gone. And join the cut to the opposite side on both posteriorly as well as anteriorly. Now, when you're going to open the tube, in the case of shearer, you have to pull the tube back so that you go into the vagina between the cervix and the vaginal wall. But in case you are opening it up with a harmonic scalpel, then push the tube so nicely that you can run the blade of your harmonic scalpel on the vault and open it. How to do a bladder dissection in previous years? This is very scary for many people, but trust me, it is very easy if you follow the lateral window technique. Again, with a shearer being done, you don't need any fancy gadgets. On one hand, I'm holding the bipolar. It is a very old video because nowadays I don't post. These videos are all available on YouTube of mine. And previous to CS bladder dissection, and just cut the tip, the top where the bladder is adherent to the at the UV fold area. Remember that in cesarean section, we do not tie the whole of the bladder, only the top of the UV fold. So once you cut it on the top, traction being given from below, you will automatically get a space, so that you will create that space. That will be your lateral window. You can insert your instrument between the cervix and the bladder and lift it up. So now these superficial cuts, again, as I say, these gas bubbles are your best friend in laparoscopy. See, and I will see above the uterines, just the uterine is below my right shearer, you see, and I have created a window already. And now all that you have to do is cut at the apex, at the tip. And the moment you cut it at the apex, you can just reflect the whole of the bladder back. So I'm on the uterine surface, cervix, cutting only on the top, and I've created the lateral window. So never try to dissect it from the center. There are times when you can easily do it. Many people might be doing it, but my advice to the beginners will be to try to go and make a lateral window. See how nicely the whole bladder can. And how do you identify you are in the correct plane? One, it will be bloodless. And two, you will see these vertical running capillaries, which will give you the impression that you are in the absolutely correct plane. So no bleeding. So if you enter any one fascia, it will bleed. So you have to be in the correct plane. You cannot enter into the cervix, neither can you enter into the bladder. So whole bladder gone. Now, how do we do a TLH for a big fibroid uterus? So here I'm using a ligature. Is an old video again. A ligature is a vessel sealing device. See, here I've begun on the right side, because on the right side I got space. I did not follow the left space. I'm dissecting here with a harmonic. You should be good at using any instrument. See the champagne effect, and in no moment, in few seconds, the whole bladder went back. Now right side the bladder, right uterine being taken and cuts being placed by the harmonic scalpel. Nowadays I don't use the harmonic a lot. This ligature is a good instrument for taking the infundibulopelvic, but not so good for the uterines, though I have taken it here just for demonstration purpose. Rather, the harmonic scalpel will be a much better. Now you see the left port came in. Since most of the uterus was occupying bulk on the left side, I dissected first on the right and then came back. So to take the cornuals, to take the round ligament, mostly in case of a big uterus, you can use the ligature. Otherwise, for taking the routine uterines or opening the vault, or using it to open to take care of small vessels, you don't need the ligature. It is more of a luxury. It's not a necessity. The left uterine lumen. So even in big fibroids, you can very well do it, provided you follow the tips of traction and counter traction. Someone is pushing right from below, just away from you, and you can finish the surgery. Remember, another tip while doing a TLH, if in a fibroid uterus, don't get terrified by the size of the fibroid. If the uterus is broad from above downwards, then understand that it is going to be an easy TLH. If it is going to be broad from below upwards, then it is going to be a difficult TLH. This TLH, way back, I did it only with a ultrasonic energy. I have not used any bipolar. No bipolar. It is done entirely with it is, I think, 8-10 years old video, and the whole surgery is being done only by an ultrasonic energy. No bipolar energy used at all. So if for routine small uteruses, you do it even by a ultrasonic energy. Only that you should know how to use it. Bladder dissection. Uterines being taken. So there is no one standard rule. You can follow so many methods and yet come out successful. Learn suturing. No future without suture. And now, how do you do TLH in a ventrofixed uterus? I injected vasopressin. This is again an old video. And here you see I use the Myma screw. Don't be in a ventrofixed uterus. You don't need a manipulator because the uterus itself is a good manipulator for you in that scenario. And I'm just using the Myma screw to pull and change my angle. And I'm proceeding routinely. Just as we do routinely, I'm taking care of the convolves. In this case, never try to go into the uterus because you will lose your way. There will be bleeding all over, and neither should you be too superficial that you enter into the bladder. So just here you see the harmonic is placing cuts exactly at the level where the uterus and the bladder was stuck. And the whole manipulation is being taken place by the Myma screw. So you should know which instrument to use and when and where. That is the most important step. That will help you to guide what is to be. That will guide you to do a good surgery. So don't be terrified. See, even in this case, I got the correct plane between the uterus and the bladder. Absolutely correct plane. Since it is not now, the step proceeds routinely as we do. Now the uterine is being taken. Now I inserted the tube so that I can know where my vault is. TLH completed. TLH in endometriosis. Now, if you wish to do good surgery, then you should not be afraid of entering the retroperitoneum. The knowledge of retroperitoneum is a must. It is mandatory. Otherwise, you will just do what is not required and not be able to complete what is basically required. And it is an art, and with practice, you can open the retroperitoneum in no time. Here, the convolves being taken. In endometriosis, I always create a film between the infundibulopelvic. See the left ureter, bladder dissection taking place. The whole bladder lifted up. The champagne effect helping you in the dissection. Right side, right round ligament, counter traction by my assistant. And in this case, I didn't create the IPF window. I saw where the ureter was, and immediately I proceeded with the surgery. And it is a nice move to remove both the uterus and adnexa en bloc like a radical surgery specimen in endo. Surgery done. So suturing with a vicryl or suturing with barb sutures is a personal choice. There is no one benefit of one over the other. Now a TLH with no manipulator. Suppose it's a postmenopausal lady, you are not able to insert a manipulator. Just hold it by traction and counter traction. You can use a ligature here. You can use a shearer here and take care of the convolves. All the traction is being taken mostly by a grasper from a left hand. See, bladder dissection done with equal ease. No issues. My assistant is holding and giving traction. Sometimes it is very difficult. You cannot give the Myma screw will also cut off, and the manipulator rod will be insufficient, or the cervix is pulled up. So in those cases, this way of dissection and doing a TLH is very easy and it proceeds very fast. So you should have multiple modalities available to do a complete TLH. This is the closure with a barb. The previous one was with vicryl. It holds no advantage, as I said, because a person who is good in suturing will take the same time, even if they use a V-lock or a vicryl. This is one of the fastest TLH which I have posted on YouTube. Unedited, it is in 5.5 minutes. If somebody has that time, do go and watch. Though the message will be not to race against time. The take-home message. So many styles to choose from. You can choose one. Slowly formulate your own style. First, you have to follow someone. Then you can pick up one method from one method from the other, and you can formulate your own style. That is the beauty of laparoscopy. Source in the beginning. Don't use two energy sources in two hands, because one foot wrong put on the pedal and you might burn the bowel or injure the bowel or bladder. Later on, you can develop and you can use two energy sources. Don't learn to earn. Learn to do it in the safest manner. First, do no harm. Be an opportunistic surgeon. Whichever side you are getting space, do it. Every energy source has a learning curve. And energy source, I just forgot to mention two things. One about the ligature and the other about the harmonic. Ligature is basically for sealing. It is basically a sealing device. Once you cook, you might undercook or overcook with a bipolar, but the ligature is an instrument which can seal it properly and gives you the beep that sealing has taken place. But it is not a good dissector. But the harmonic is it uses piezoelectric crystal. It is a very good dissector. The problem is it might create wrong tissue planes. And no TLH requires fancy gadgets. If I can give you one important message, this is this. No TLH, in fact, no TLH requires any fancy gadgets. You can perform it with very simple instruments. You don't require any glowing ureters to do a good TLH. Many gimmicky instruments and things will come up. The problem is that when you are young, you do not have money and to purchase these setups. And so it is a wastage of money when you are investing so much of money on these systems, and you don't require them when you are so experienced or you have acquired the art of dissecting the ureter so that you don't need these instruments. And mainly plan the surgery the night before. The surgery is done in the mind of the surgeon night before and not on the OT table. And remember, my God, Prabhas God to Sailesh Puntambekar sir, he always tells anatomy, anatomy, anatomy. The subject that we hated the most during our MBBS days is going to be your best friend. Believe me, if you want to become a good surgeon, it has to be anatomy, anatomy, anatomy. Thank you. Thank you so much.
Thank you, Mohapatro. It was a really great, enlightening talk for the today's webinar. As many of the beginners of the laparoscopy and a lot of variation in the audience here, you spoke even from the very entry to the position and also energy sources and also manipulatory, everything you have very clearly spoken. But as a basic, this one, any vision port, anything you would like to tell, one line? Of course, it may not be for you. For the beginner, the entry, the very first entry with the vision port, anything like you would like to highlight about it?
No, ma'am. My main entry port is always, I use the Palmer's point. I use a Veris there. Again, as I follow Sailesh Puntambekar sir. So I put a Veris there. And in cases which have no previous surgeries, I directly go with a 10 mm port in the supraumbilical port. But if there are previous surgeries, I put a 5 mm camera in the Palmer's point, see whether there are additions or not,
that is another point.
and then come back with a 10 mm port. That is the best way for anyone. So again, no, we don't need any vision port.
Yes. No. Like some people do use it. So I just wanted to know your views. That's all. Because in the beginning, especially if there are additions expected, that's another thing. And you said, of course, the glitter, everything is not very necessary. But in grade 4 endometriosis and all, like sometimes I think indocyanine green dye can be of help if it is.
Very humbly, I would like to say no. I do at least 4 to 5 endometriosis per day, every day. And not even a single case do we need these glitters. Trust me, they are gimmicks. And mainly, whenever you have hard nodules of endometriosis, the ureter will get hidden in the nodules. You will not be able to see it. Rather than propagating that to our young budding surgeons, let us advise them to learn the art of dissecting the ureter, to trace the
They should
ureter.
start with the beginning cases only, not with the extreme endometriosis in the beginning.
And that is not at all a very difficult job.
Can
job
I
to trace
have
the
a
ureter.
question,
If
Prabha?
we
Yes,
invest
it's over.
time,
Yes, sir.
One more last. So your talk with the no switcher, no future, and also with Jugad, everything has really been very impressive. Thank you for this
thank,
beautiful, very informative talk. Shobha, to you.
thank you, ma'am. Thank you.
Thank you, Pari. So I just wanted to ask a little finer detail about the vault closure.
Yes,
Mm,
ma'am.
How two things. One is um, in difficult cases, how to keep the ureter away. I know that it really anatomically doesn't come that close in simple cases, but then sometimes it gets kinked if the suture goes a little below. That is one thing. And secondly, uh, what else I wanted to say? Yeah, what exactly can be done to prevent vault prolapse? These two things I wanted to
Yes,
know.
ma'am. One is the first, the answer to your first question will be whenever we have endometriosis, we dissect it till the ureteric tunnel, ma'am. In both the sides, my ureters will be traced till the tunnel. So when I'm taking the vault, I'm absolutely sure because my ureters are bare and I can see them very, very nicely. यहाँ पे हो सकता है is not the answer. We should not presume and assume. We should be confident that the ureter is there. If the need be, take 5 minutes more, trace it well, and then take it. And in an attempt to close the vault very properly, do not go too lateral and injure the uterine lumen. And in that process, again, coagulate the uterine and then injure something else. So that is the first point. And the second question, what is that, man? Sorry, I forgot. Hello?
Preventing vault
Vault
prolapse.
prolapse.
Yeah, I normally cut it above the uterosacrals. So I have never had the need to do anything to prevent the vault. I do not go and cut the uterosacrals. I'm way above normally. So it helps me. It has helped me. And we should be another very important tip, not related to vault prolapse for the beginners. Take good thick bites of the vault. Don't take superficial bites. Take good thick bites. Only then the post-operative complaints of vaginal bleeding and discharge will be less, which otherwise decreases the patient's morale and brings down your confidence too that
Yeah,
I am not doing good TLH. That is why the
correct.
patients are coming back with complaints of
Correct.
vaginal.
Mm. I think I can
Can
go
I
ahead
add
and
one
explain
thing?
the reason for that, and that is because the edge is cauterized and it is
Hmm.
likely to have some reactionary fluid. But
Hmm.
if it is internalized due to thin bites, it gets resolved in the peritoneum. If it
Yes, ma'am.
remains
And that is why
exposed,
it should be
then
And
short, but
one is likely
that
to face the
uh,
discharge.
yeah.
Why I asked about the vault prolapse is that some women have a tendency, and so if we pick it up during an open case, we tend to do things like Moskowitz,
Moscow and all.
Yeah.
or if we are doing
Madam, same.
especially a vaginal hysterectomy, then we tend to do Meckel's
Hmm. Hmm.
So these are things which are available to us in alternate, no.
Yeah.
Madam, the same thing can
Here
be,
what we
can
can
I
do.
interfere? Can
Yeah,
I tell? Madam, the same thing can be done laparoscopically
Yes,
also.
absolutely.
Yeah, we do take, if you feel that there is an introsil-like thing and all, you can put the
We
same
can take a
Moscowitz by
Moscovite.
laparoscopically.
Absolutely. Laparoscopy. It
Yeah,
is very easy, ma'am.
easy. In
Another
fact,
two
it is
minutes.
more easy. You can
More
see
easy.
uterosacral and you can separate the ureters there and then you can take both the uterosacrals and then peritoneum over the rectum and then you can tie.
yeah, sure.
So same thing can be done, ma'am, there.
Prabha, one thing
And
which
Huh.
I feel that surgeons today, because we are no longer budding, the problem with laparoscopy is many of us have been doing it for years, but without much improvisation. Tend to, yeah, we tend to. Why? The main principal reason is that we are all, into vaginal route. So,
Yeah.
two or three of the cases which Dr. Mohapatra showed, I would have done of a vaginal hysterectomy.
Yes,
So,
ma'am.
No, no, no.
Actually, it's
so
a,
that
Vaginal,
yeah.
that we kind
Madam,
these
I
were
will
the
show
tend
cases
to
you
remain at the
totally.
same level on expertise.
Yeah.
Okay, I'm
Madam,
just saying.
actually
Yeah,
there are advantage and of vaginal and laparoscopy has its own way of advantage to the patients and the disease per se. So there will be a big debate if we say, but I will show you today's one case where I purposefully put
yeah,
the today's interesting case discussion
absolutely. I
where you
don't
would
deny
have
that it is
said that
useful.
yeah, this was the how the laparoscopy would have helped that woman if you would have missed the same case, if I would have done vagina, I am very good actually propagator of vaginal hysterectomies. I do lot of NDVH along with this. But if by seeing these cases, we can come to know that there also, of course, we have to individualize the case, which should be done best with the lab or NDVH. But
Even I have
there
very
are
good
definitely
experience.
advantages.
I have done up to 18 vaginal hysterectomies a day. So I have, but ever since we have started, though, for example, endometriosis, there is no
Yes,
chance, no need of
yeah.
taking
Much
any chance
absence,
because you are seeing
especially
it continuously.
endometriosis.
Yes,
Yeah,
yes.
Yeah.
ma'am.
The
That is the
same
reason.
thing
Absolutely.
as
I agree absolutely, and that is why those small ones which I showed were very way back
No,
old videos. They are
I
not new
know they
ones.
are old videos. I know that.
so
Yeah,
we
yeah.
have to individualize the case. Actually, we know everything. We know NDVH, we know laparoscopy and all. But sometimes we have to do open also, even though you are expert in lab.
and
Such cases
50% of
also
the
will
people
come.
don't know open now because they all are starting from laparoscopy. There is
So,
only, I
yeah,
think,
as a
mine and
part of
Shobha
my career,
As
I
per the
open
have
need
done.
for
generation.
that patient, we have to. If you suspect sarcoma on table, definitely you have to open. Last time I have a patient which has a very big uterus, and we thought it is adnexal mass on MRI and all, but it was arising from the uterus per se, and it was looking full sarcoma. It was 32 weeks size uterus. So we said that for patients' benefit, we opened, and it turned out to be actually degenerated
Most
multiple
importantly, the
different
last
stage
wash
fibroid.
that we give in laparoscopy and see that there is not even a RBC seen, that gives you a good night's sleep at night. That is I think, the best thing that can happen in
Yeah,
laparoscopy.
Yes.
correct.
Thank
We
you,
need not
sir.
struggle and
Thank
presume.
you very much.
Yeah,
Thank
thank you.
you. I
And
think we
really,
can
we are
proceed,
lucky
Prabha.
today to get a speaker like GSS sir, who is a pioneer of his own Odisha of so many techniques and technology. And really, I am
Thank you,
very
Baba.
happy when I just messaged him. He was ready to give that talk, and he accepted very easily
Anything for
and
you, Prabha.
guided me very nicely. And really happy for Parimala Devi madam, who is a Guinness World Record for her CA cervix prevention things. Such a great faculties I have got today. Thank you, sir.
Thank you,
Thank you.
Prabha
Thank
and
you, thank
Shobha.
you.
Yeah.
Thank you, ma'am.
Always happy to learn from everybody. Thank you
Yes, ma'am.
for
Thank you,
this.
ma'am. Thank you, sir.
Thank you.
Uh,
Welcome.
I think we'll
Thank you,
next.
GSS Mahapatra sir, and thank you, Parimala madam, for chairing this session.
Welcome.
Now let's move on to the second session by Dr. Egbert Saldana. I request Dr. Sri Prada Vanikar to please chair the session.
Good evening, everybody.
And Dr. Sripada Vanikar is a consultant gynecologist at Cloud9 Hospital and Apollo Hospital, Bangalore. She is the executive committee member of BSOG and also holds her fellowship in minimal invasive surgery. She did her master's from AIMS, New Delhi, and her from senior residentship from PGI Chandigarh. Over to you, ma'am.
Thank you, Dr. Priscilla. We know that every surgeon, I'm sure, will remember their first major complication, not because of the technical difficulty, but more because of the emotional impact it carries. So, in today's discussion, it's not about the fear, it's about the preparedness. So, we have Dr. Egbert Saldana, who will talk about how to prevent complications and how to manage them safely. Dr. Egbert Saldana is a consultant obstetrician and gynecology and a laparoscopic surgeon at the Shriji Hospital in Ghatkopar and also in Zen Hospital Chamber. He's an honorary obstetrician and gynecologist at the Municipal Hospital in Govandi, and currently he's the president of the IMA Chamber. Over to you, Dr. Egbert.
Thank you, Madam, for those kind words. At the outset, I must thank the Karnataka Society of Obstetric and Gynecology, the Endoscopy Committee, and of course, the Dr. Prabha for giving this opportunity to me to share some of my thoughts, probably being a laparoscopic surgeon for so many years. I think after that crisp talk by GSS Mahapatra, I will be repeating a lot of things. And I think I must say that I've always been happy to meet Prabha, an excellent laparoscopic surgeon herself. And she always has something new to talk about, and it's always a pleasure to meet her. And I couldn't resist saying no to her. Yeah,
Thank
so
you,
I
sir.
think we have come a long way as far as laparoscopy is concerned. And we all know that laparoscopy now is emerging as the standard of care in most of the benign gynecological conditions, including TLH. So basically, to start off, as we know that the advantages, I think, of laparoscopic hysterectomy, we all know that it causes less pain and a quicker recovery of these patients. But I think definitely there are specific risks that the surgeon must anticipate. And the effective prevention and management of the complications require understanding of their classification, the risk factors, and the treatment protocols. So this presentation, I think over the next few minutes, I'm going to cover the complication types, the risk factors, preventions, probably the pre, intra, post-op, and I will discuss everything. I mean, the surgical entry techniques, the energy sources, the trocar safety, and the management algorithms for common complications. So basically, when we classify these complications, we classify them as the entry phase, the intraoperative, early post-operative, and late post-operative. They're also categorized by their types. I mean, we have the anesthetic issues, we have the abdominal wall, the trocar injuries, vascular injuries, the GI complications, and the urinary injuries. Major laparoscopic surgeries like laparoscopic hysterectomy have higher complication rates, that is 0.6 to 18% than the minor ones, reflecting the complexities. So understanding these classes guides preventions. So basically our aim is to prevent and not to create the complication. And I think that is what we have learned over the years, creating the complications, what best we can do as far as preventing these complications, whether it is early with trocar incision, during surgery, or probably late as far as the hernia management, prevention of hernias and adhesions. So what are the risk factors? So, I mean, you must understand that first is the surgeon's factor. So an inexperienced and technical errors dramatically increase the risk if you are not surgically trained. And of course, as GSS said, I think knowledge of anatomy is the key. I think knowledge of anatomy and the proper skills. So I think that we need to upgrade our skills at every point of time. We need to practice, practice, practice. And I think keep understanding anatomy all the time to become a better surgeon. And that probably will help you prevent and decrease your number of complications. Patient factors. There are certain factors which probably you can see in these patients, which probably could tell you that this patient is likely to have, complication like obesity, prior surgery, or any complex pathology like large fibroid or endometriosis. So these are patients who are more likely to have injuries or complications. Disease, of course, like endometriosis or any other patient who has prior surgery, they are at major risk for bowel injuries. So this we have to keep in mind. Or, complex surgeries like large uteri have a higher complication rate, or endometriosis also have a higher complication rate. So we should keep this in mind. And of course, as far as the entries like adhesions, previous laparotomies, they have a 68% were present in 68% of the with bowel injury during entry. So this was a study that was done. And the high BMI patients, the entry becomes more difficult and risky. So these are the things that you have to know before you start surgery. So basically, coming to the entry-related complications, I think the primary step, and I think the most important step in laparoscopy is pneumoperitoneum. And I think major complications have occurred because of during the entry, whether it is bowel, whether it is vascular, or whether it is because of the pneumoperitoneum. So I think this is the only blind procedure in during the full surgery. And I think this is the one, I think I always tell my students that, once the most difficult part of laparoscopy is getting the laparoscope inside. Rest of all of it is technology. So, and training. But I think this being the blind step, you need proper training, you need to practice, and you need to do enough number of cases before you can probably to reduce your complications. So as we all know, the most common that we use is the entry technique that we use is the closed technique with the Verries needle. Very simple. We put in the Verries needle. There is a definitely once we know that we are in, there are 3-4 tests we can do. One is we do the saline drop test, or then the most important is the very initial intra abdominal pressure. But sometimes if you are in doubt, remove and try again. Now here we had a patient whom we put in a varies, and then we realized something was wrong, and we realized here this is what happened. We had injured the bowel. Of course, easy to manage. Just probably if you know to suture or just take a suture or do nothing. But so these are things that happen. So you have to understand that okay, these things can happen, predict the complication, and manage them accordingly. The open technique, so basically because of all this, I think among the surgeons, the open technique has gained a lot of popularity among the surgeons. So basically it is about making a small incision in the fascia and the peritoneum under vision. The advantage is it minimizes the blind insertion, definitely reduces the risk of vascular injury, and allows immediate control. The disadvantage, it's a longer setup, potential gas leak, and wound issues because the very high chance of infection and hematomas. Of course, many of us basically do the direct entry also with the trocar. And since there is a group that says that the complication with this is much less because it's only a single procedure, unlike the varies where it is a three-step procedure where you do the pneumo and then it's a two-step procedure. So first you do a pneumo and then you insert the trocar. So this being a direct entry, the failure rates are less. Plus, it is much easier to get in an abdomen which is not inflated as compared to a abdomen which is inflated with gas after a varies insertion. Of course, some madam was asking us about the optical trocar. Yeah, so basically, there was a time when we thought that optical trocars would reduce the chances of injury to the bowel, but I just want you to see what happens. So we were using optical trocars, and this is what happens. We are directly into the bowel. So basically, now we have realized that what the optical trocar does is probably tells you that you're in the bowel. And how do you manage this? The first thing to do is do not remove your trocar. Go in enter into the peritoneum cavity through another port, identify the injury, and manage it accordingly. So the plain port sites to avoid again when you use the secondary trocars, I think the very important to see when you're doing it to do it under vision. You can trans-illuminate the vessels, and you have to do it under vision. Whenever you're going in, your trocar should be perpendicular to the abdominal wall to minimize the shearing. And even when you're removing it, you remove it under direct vision so that you don't cause tears or pull the bowel with it. So of course, if you have to know a knowledge of anatomy, I mean especially the vessels of the abdominal wall, so that you can reduce the chances of injury. So here we were doing putting in our second port, and this is what happens when you don't do it when you don't use the proper protocols. Of course, easy to manage. What you can do is either you can take the port closure and close that, or you can use the bipolar from the other side and bipolar it. And sometimes you can just put a Foley's bulb, inflate it, just keep pressure, and it can stop. So coming to after finishing, so this is the most common injuries that we see, the port site, the port entry injuries. But there are some others is because of the procedures. Of course, the GI injuries can occur, quite common, are not as common, but are the leading cause of death in laparoscopy, and about half occur during entry and half during dissection. So I told you, major surgeries occur, I mean, major complication of the bowel occurs during entry. So we have to, high vigilance is needed to identify the risk factors like adhesions, endometriosis, have a low threshold for inspecting the suspicious areas. How do you prevent? So evaluate adhesions, endometriosis. So good preoperative evaluation of these patients is very important. So patients with endometriosis, adhesions, you have to predict that these are the patients who can have problems. So you give them a good bowel preparations in severe disease or prior to GI surgery. Intra-op, you can carefully retract the bowels out of the field using packs, graspers, or try as much as use scissors or low power coagulation near the bowel. Avoid blind cutting. Whenever you're using dissection, use the lateral technique so that you keep the dissection the planes away from the bowel. When you're doing endometriosis and you're closer to the rectum and probably you're suspecting a rectal injury, then probably you can do a leak test. That is, you fill the pelvis with saline and you inflate the rectum. You can see the bubbles, like how you see it when you're trying to find out a puncture of your tire, or we can inject methylene blue. So this is an algorithm for how to manage the bowel injury prevention. So basically, you have to understand that there could be primary port. You have to do a good history evaluation, good bowel preparation. These patients, you have to do a good primary port insertion. So whatever you can do it, either the umbilicus or the palmar's point. You have to confirm the placement and inflate the abdomen. Intra-op, insert the primary trocar diagnostic look for adhesions, identify the adhesions. You have to decrease the risk by avoiding blind sweeps, careful tissue manipulation, check for injury upon removal. Secondary port, of course, always under direct visualization, transillumination, and controlled, slow, steady pressure. So these are all the algorithms to prevent bowel injuries. And of course, don't be too overzealous when you're near the bowel. So sometimes you feel there is nothing, and you don't identify, or you're a little more bold, and this is what can happen. So you have to be very cautious. So use a scissor and be very cautious when you're working with the bowel. How do you manage the bowel injury? So if there's a small enterotomy seen intraoperatively, close it into two layers with either Vicodil, PDS, or Mersilk. Trocar perforations, very often you have to see whether there is an entry point and an exit point. If you cannot manage them laparoscopically, then probably many of them may require a laparotomy. And if you have injured a large bowel, then probably you must even think of resection and diversion. If there is a thermal injury, sometimes you might see a small spot on the bowel, because of your cautery touching the bowel. You don't need to do anything. Probably just take a suture to close that and everything will. But if there is a bigger burn that can cause necrosis, you need to excise the wide margin and suture in 1 or 2 layers. Of course, delayed diagnosis. So how do you suspect whether a patient has a leak? So one of the most way is these patients will have abdominal pain, fever, ileus. I think after every laparoscopic surgery, the patient should feel better. When you operate the next day, definitely you should feel that your patient should look better. But if your patient is, say, tachycardia, not looking very good, you must suspect an injury. Immediately probably do a CT contrast. You'll be able to find the leak, start them with broad spectrum antibiotic and a surgical intervention. You can either go in by a laparoscope, check it out, and probably you can just excise and do a primary closure, a closure with a vicryl suture. But if there is a bigger injury, then probably you might even have to do a stomy, a diversion, and then probably do a closure at the later date. So this is the way you would manage a bowel injury. Coming to urinary tract injury, bladder, of course, we have seen about 0.1 to 1.5% of the patients do have bladder injuries. And the time when you have these bladder injuries is when you're doing your anterior dissection or at the time of colpotomy. How do you recognize? Basically, you will suddenly see that there is more fluid in the vagina, hematuria in the catheter. And if it is there, all you can do is I probably inject methylene blue, identify and close in 2 layers, and you can leave a Foley's catheter for about 7 to 14 days. If you have missed it, then you will end up with a urinary leakage fistula, and probably this vesicovaginal fistulas need a later surgical repair. A few steps that we would do to prevent bladder complications is start in the midline. Of course, you can either start in the midline or the lateral approach. We initially used to do the midline approach, but now we do the lateral approach. Use the gas as your friend to open the planes. And I think in bladder dissection, your lower hand is very important. You need to lift the bladder with your lower hand and do millimeter by millimeter dissection. Sometimes, if it is difficult to find out the bladder margin, you can inflate the bladder to delineate the margin. And another thing you can do is you can use a vaginal tube to identify the anterior and the posterior fornix, and you can use the bladder, use that as a platform to dissect the bladder down. So I was showing you this is how. So you lift the bladder and use the shearer, scissor, harmonic to open the peritoneum and dissect the bladder. But sometimes again, after all that happens, you may still open the bladder. All you need to do is probably put in methylene blue, find the leak and suture. You can suture with Vicryl in 2 layers, and that should be okay. Another important, I think, one of the major complications probably in initial days is bleeding from the uterine vessels. And I think I think that used to be I think we never, initially when we started, we never, the scare used to proceed from the uterine onwards. And I think there are a few things that we have done over time which has reduced that also. So basically you skeletonize the uterine vessels well, you take a good length and you coagulate them perpendicular to the vessels. Now, one thing is you must understand that the anatomy of the artery and the vein. So it's very difficult to injure an artery, and whenever you injure an artery, there will be a spurt. So all you need to do is hold it and coagulate it. But it is the veins that give continuous oozing, and the best way to do it is just go on the medial side, on the specimen side, and coagulate, and most of the bleeding stops. And in the initial days, we never understood this anatomy, and that is why we went on cauterizing laterally, and that's how we did injure the ureter. We did thermal damage to the ureters. So I think understanding anatomy and developing your skills over time definitely would reduce the complications. Again, opening the vault also some in initial times was difficult. So you can either use a monopolar hook, you can use the harmonic. Of course, now most of us are using the sharer. I think the best thing to do is to use a vaginal tube, which can which would make it prominent, and you can cut over it. And especially when the planes are distorted, you cut as close to the cervix so that you have enough good length of the vagina. Dissect the posterior peritoneum as medial as possible to get good length of the uterosacral so that you get better. So what we do is when we suture, we take the uterosacrals along with the vault, so that would help in vault suspension. I think madam was asking about what do we do. So we dissect it, we take a bite on the uterosacral and the angle, and that definitely helps in for vault suspension. So ureter is another thing that I think is where it was a nightmare for the laparoscopic surgeons, because it was more common with laparoscopy because of its anatomy. Especially it is close to the uterine vessels, it's lateral to the cervix and near the infundibulopelvic. And again, so it can either be due to thermal spread from the cautery that we use, or kinking or ligation when we suture the vault or the uterine vessels. Very difficult to recognize. Sometimes it is missed at the time of surgery. But of course, post-operatively, these patients will have typical flank pain, anuria, raised creatinine. And the prevention is to identify the ureter at the pelvic brim and avoid energy near it. I think you of course learning anatomy, and once you learn anatomy and you start dissecting the ureter, I think life becomes so much easier. Yeah, there are now camera systems which use indigo carmine, which can definitely help in identifying the ureter and making your surgery a little safer. Management, if at all you find the injury at the time of surgery, you can do either ureterostomy, or you can do a ureteroneocystostomy if it is a distal ureter. But if it is recognized late, then you need to do a stenting, drainage stenting, and then a reconstruction surgery at a later date. So here we have a patient who had a ureteric injury during TLH. So the first thing you do is basically you finish your surgery, you finish the hysterectomy, you finalize, and then probably you can go and dissect that ureter. You can go and dissect that ureter and then do a end-to-end anastomosis. So vascular injury, of course, I think these are the most catastrophic because they are life-threatening, and even small arterial and venous tears can bleed massively. To prevention is, of course, insert your trocars laterally, use the open technique, trans-illuminate to avoid epigastric vessels, and always keep suction and instruments ready. So what is the immediate management if there is a injury? Just do not panic, call for help. stop inflation, apply pressure on the sponge, and have a very low threshold for opening these patients. I think you can, if you could manage it laparoscopically, use laparoscopic clips or suture if possible. But if the bleeding is not controlled, if it's a large vessel, convert into a laparotomy. And I think and immediate vascular control and repair, because every second counts. I told you about the inferior epigastric artery. You can either clip it laparoscopically, you can cauterize it, you can take a port closure and close it, or sometimes just put a Foley's catheter and give pressure and it stops. So again, here is a algorithm to manage bleeding, intraoperative bleeding. So maintain a high index of suspicion and whenever there's bleeding. So monitor tachycardia, hypotension, clear the blood with suction, use clips, bipolars, sutures, whatever is possible. And if severe, you can temporarily pack or or tamponade area, stabilize the patient. Then definitely do not hesitate to convert into a better exposure if laparoscopy is ineffective. So I think have a low threshold, especially in vascular injury, because here time is important. Call for help, keep blood ready, and probably open up these patients, and you will not regret it. So pre-operative strategies, of course, you need to, so coming to the prevention. So what we can do pre-operatively is basically proper assessment. So MRI, sonography, probably a good examination. So depending to evaluate the size of the uterus, whether there are fibroids, endometriosis, and of course, accordingly devise a strategy. So I think your surgery, as Dr. GSS said, your surgery has to be planned the day before, not on the table. Good bowel preparation, of course, be in patients who are not doing extensive surgeries, probably simple thing like a low residue diet with a Dalcolex is good enough. But in patients where we are doing resection anastomosis, so we are endometriosis, then probably something like a PEGLAC would be important. Of course, place compression devices and start heparin or DVT prophylaxis. And planning, so see that there is proper blood available when for large uteri, unexpected adhesions, and confirm operative team experience with difficult anatomy and have advanced instruments, so that definitely would prevent any complication. So what are the intraoperative? So your team setup is very important. I mean, you need to know your time, or to confirm you need to give prophylactic antibiotics, good positioning of the patient, you know your equipment. I think check your equipment well, ensure your monitors, insufflators are functioning. So your team setup is very important. Of course, position is a lot of the injuries can occur if you don't give proper position. So those also are complications. So you should provide that. I think so what we give is a low lithotomy or a Trendelenburg position. Again, the hands tucked at the side to prevent nerve compressions. We have seen patients having brachial plexus injuries, so you need to prevent those. Post-op, I mean, port placement, very important, so that it is ergonomically comfortable for you and for your assistants. I think have a low threshold for using manipulators. Either you can do vaginal manipulation or you can use the myoma spiral. Gradually increase the pneumoperitoneum so that to reduce the cardiopulmonary strain. Very gentle tissue handling. So gentle tractions, clear dissections, use retractors assistant to keep the bowel and momentum away, and maintain constant visualization on the active instrument, especially the cautery that you're using. Energy settings, again, keep it low, short activations, and especially when you're using it in your critical areas, be very careful. Those are the areas probably you could use a cold scissor or a harmonic scalpel. Energy sources, of course, we use monopolar, bipolar. Check your instruments, your hand instruments very often, so that, especially when you're using the monopolar instrument, so that, there is no leak anywhere else. Apply energy perpendicular to the tissue to avoid unintended burns. Ensure the active electrode is not near the unintended tissue like the ureter, and use irrigation and suction to cool these tissues. You can use what is called as the clamp suture cut technique, where you hold, grasp the tissue away from the vital structure before cutting, so that and test that the lateral heat is controlled. And I think if you use bipolar and proper dissection, and monopolar also, but with dissection, I think the aim is to dissect. I think the thermal complications are definitely will be low. So basically, what we learned was initially, because we used very crude bipolars, monopolars, we learned to dissect. So we learned to dissect the uterines and then coagulate, so that we use minimal coagulation, because we did not have those advanced bipolars. We didn't have those refined bipolars. So that is why we learned to dissect. Second thing is, Sutures. I think once you know suturing, you will be in a different zone. So if you're stuck anyway, you can just take a suture, and of course, suture definitely will make a difference. So these are things that you should know. I think proper dissection, minimal use of current and suturing techniques would definitely decrease your complications as far as the energy sources are concerned. Then, of course, recovery, ensure that there is adequate pain control in these patients. You can use long-acting local anesthetics, early mobilization, thromboprophylaxis if there is a prolonged surgery or any patient at risk. Wound care, of course, you have to keep the incisions clean and dry. Of course, give proper preoperative antibiotic prophylaxis. You need to monitor these patients very closely for fever, tachycardia, pain, and of course, bleeding. So basically, anytime the patient, of course, post-surgery should feel better. She should look better. I think when you walk in, you can definitely see a patient who has been operated laparoscopically definitely will look much more fresh the next day. But if she's not looking good, be under suspicion, look for pain, hematuria, and of course, keep a watch on her so that you can pick it up early and manage her. Of course, vascular injuries, as we told you, have a low threshold for laparotomy. Keep your open trolley always ready. Keep your clamps, your packs, everything ready, and have a team in place. Bowel injuries, as I told you, I mean, you can manage them laparoscopically if you know suturing. There is no harm. Even today, we are suturing the bowel with barb sutures. So you can do if there is a large injury with a cautery, you can excise and suture. But take good sutures. Post-operatively, if it is missed, do a CT with a contrast, identify, give antibiotics, drain, and probably surgery once peritonitis settles. Urinary injury, I told you that if it is the bladder, probably you could on the table suture it in 2 layers, keep the Foley's for 7 to 10 days, and should be okay. Ureteric injury, on the table you can do an anastomosis, but if it is delayed late, you have to stent, drain, and delayed repair. Of course, another thing is port side hernias. How do you prevent? All 10 mm, any port which is more than 10 mm should be closed under vision, and especially when you're removing the the trocars, please remove it under vision so that you don't pull the bowel with it, and that can get stuck there and cause an hernia or sometimes even a bowel problem. So these are all the late post-op complication that you can hernias, of course, because more with bigger port sizes, adhesions, of course, definitely the adhesions are much less with laparoscopy. But I think the way you handle tissue, the way you dissect definitely decreases the chances of adhesions. Of course, fistulas, whether it is vesicovaginal or ureterovaginal fistulas, because of unrecognized injuries, so they need to be repaired later once the inflammation settles. And of course, sometimes you get persistent pain due to nerve entrapment or residual endometriosis, so they have to be managed accordingly. So the key takeaways is that for planning to closure, surgeons, OR team must anticipate the risk. Surgeons' knowledge and skill are paramount. Knowledge of anatomy is very important. Safe entry and energy use. So careful technique with entry and control energy use to prevent many injuries. Early recognition. So many complications like bowel ureter are missed intraoperatively. So maintain a high suspicion and inspect anatomy before closing. Preparedness. Always have a plan for managing bleeding or organ injuries. And education and team. I think regularly review complication, near misses in morbidity meetings to improve the practices. So I think I've tried to cover the gamut of complications and their management and prevention. So thank you, and I'm open for questions.
Thank you, sir. It was a really elaborate topic and you covered it beautifully from entry to intraoperative to post-op. Anyone has any questions to ask? Yeah. I remember one of my in my younger days, a senior colleague told me the only way to prevent a complication is not to do the surgery. So having said that, I think what we need to understand that complications are not failures. It can happen to any one of us. What's important is that we recognize it early and manage it well. As surgeons,
So I think anytime you have a complication, I think that the best thing to do is try and operate, do the next case as soon as possible. Probably if you have a surgery pending, the easiest thing to do is to say, no, I don't operate now. I think go and operate. It's a thing more in the mind. I think once you get over that fear, I think I'm not saying you should be overconfident also that, okay, anything happens, not to be bothered. But I think you need, it disturbs everybody, even the most experienced surgeons. I mean, after so many years, I'm sure GSS will agree with me. It does definitely disturb all of us. But you need to get over that. You need to get over that. But I think more than that is you need to manage the complications. Have a team in place. When you're suspecting that this patient can have a problem, probably keep a urologist, keep a GI surgeon with you, so that your responsibility is less. You share your responsibility, you share your problem, and then definitely make it easier for you.
I agree. I feel when you're a team, you're kind of emotionally involved with the patient, but the other person who's assisting you will be more rational in the approach sometimes. So it's good to have a team effort, especially when you've landed up in a complication.
Yeah.
And also, ma'am, I would like to add just that we should not try to conceal anything from the patient party if something goes wrong. That goes a long way in building up confidence. See, this has happened. We tried our best, but this has happened. We have called a neurologist. We have done this, and then the patient. But if you're trying to conceal something, so trying to manipulate on, and then they come to know some, then everything will go haywire. So we should be very honest whenever something goes wrong. God forbid.
Yeah.
I think the message that GSS and I want to give today in the talk together is, one is, I think you need to know anatomy very well. Second thing is, I think just keep upgrading your skills at all times. I think you don't need fancy instruments, but I think skill upgradation is very important. And the third thing is, keep it simple. Don't try heroics. And I think that has worked for us. We have come a long way. We have done everything possible. And I think we have tried everything, and we have come a long way. And we realize this: the more simple you keep things, the easier it is, the less problems it is. It's when you try to do, hi-fi things, things which are not beyond you. And that's when you land up in trouble. I keep telling my fellows, and currently I have a fellow from Karnataka, Dr. Usha from Raichur. So I keep telling everyone that always plan the surgery. If you fail to plan, you plan to fail.
True.
The count. So, Prabha, can I say a few words?
Yes, definitely. Yes, ma'am.
I really agree with Sri Prada, because there are many senior surgeons in BSOG also who have constantly told us that anyone who says that I have never injured a ureter has not operated enough. So that is a very standing truth which goes. Now, I just had one question with Dr. Egbert, and the other thing which all the experts have brought out is never shy away from confronting your problems, whatever has happened. And I have always told my staff, if there has been a complication, then be there with the patient second to second till it is solved. And when they go home also, when they come back for follow-up, see that you see them first, bring them first in the line and see them first, and talk to them and the family in a way that they are reassured, and you should show more care. Yeah. My one question which I had to Dr. Egbert is, when the woman gets admitted for surgery, then what we would have done in whatever I do, I can just share that I keep them only on liquids for that day. And also, the bowel preparation is slightly confusing. I just want to know what will be adequate, what is best.
So, madam, I think if you're doing a simple TLH where we are not suspecting adhesions or there's no endometriosis, just liquid diet for 24 hours and 2 tablets of Dulcolex for 2 days is good enough. So most of our low risk patients, we use this regime, and that has worked for us. But I think whenever you are suspecting adhesions, endometriosis, then probably you can use your Colopreg or your Peglac, madam. No, ma'am. And for my endometriosis cases, I would like to add here that I keep them on low residue diet for at least 3 days. Then I come for a liquid diet for 1 day. And then whenever I'm suspecting that I need to do a discoid or something, so that is the extra thing. Otherwise, in 99% of the cases, 2 tabs of Dulcolex and prior to that 24 hours liquid diet is more than sufficient. Yeah, madam, I just want to add to what GSS says is that initially we used to use PEGLAC in a lot of patients, and patients used to pass stool, and then next day we find these patients having severe electrolyte imbalance. So I think we don't need to give that much of bowel preparation to patients who are low risk. For patients where we are going to suspecting bowel, where we are going to probably think of operating on the bowel, or we are thinking of adhesions. So those are the patients in whom probably we could think about giving them the Colopreg or the PEGLAC, madam. And of course, a low residue diet 2 3 days prior with the liquids 24 hours before.
A
Sir,
pro
I
tip for the
have
beginners
noticed.
regarding bowel in diabetics, even if there is no endometriosis, many times handling the bowel will be difficult. This is a tip for the beginners, and more so if he's a bit on the obese or the higher side of weight, then handling bowel in diabetics, I've found it normally tends to come in your way and pushes into the pelvis. And in all routine cases also, it is wise that you start from the sigmoid, remove the physiological additions. Then you will be able to push the bowel, park the bowel properly, and then start with your surgery. Don't be in a hurry to just start the surgery. See where the bowel is stuck, the physiological additions, push it back, park them properly, and then you can begin your surgery. That will
And
make
even
your
if that
life
doesn't,
faster.
and even if that doesn't happen, you can always put an extra port. I mean, whether
Yeah.
you're having 3 ports or 4 ports, it hardly matters. I think nowadays we are going into minimal invasive where people are single sills and all that. I think one 5 ml port hardly makes a difference. So if you put one 5 ml port, and you can always make. So ultimately, it is to make the surgery safe,
Safe.
to keep that bowel away from your area of where you're going to work. And I think putting one more port doesn't make any difference.
Yes, sir. Ma'am, one more thing about the PEGLAC. Now, means as Saldana sir was telling, only for endometriosis case and all, we give PEGLAC for those cases or previous LSAs or kind of adhesions expected. And after the means we will start suppose tomorrow morning we are operating at 8 o'clock. We will start the PEGLAC today by 6 o'clock in the evening. By 7:30 it will get over, and they will pass the motion by by 9 and all they will be free. And after 10 or 10 o'clock we keep NBM. Before that I give them to drink two times ORS. Somehow means since that I have started, I would stop giving them RL. IV RL previously we used to give
Correct.
for electrolyte problem and all. So after that we'll keep them NBM, and I even
Neglect,
allow them.
etc. They should be timed exactly
Yeah,
12 hours prior.
yeah,
Not,
yeah.
oh yeah,
Not
that gap has to be
huh.
maintained.
You should not
Very
give them
important.
too early PEGLAX or
Yeah,
anything.
that is yes.
Otherwise, your bowel will become more distensive.
More distant. More
Yeah.
distant. Yeah.
So
So if you are
at least
planning a
8
surgery, then
hours.
it should be ideally 12 hours just prior to the surgery.
Before, yeah, 8 to 12 hours prior.
Yeah.
You should not prepare
So
it too
basically,
early.
when you're operating in the morning, around 4 o'clock, you give your PEGLAC, finish it by 8 o'clock, let the patient have liquids till 10 o'clock, and then NBM probably.
Yeah, yes. The
And
same
normally that's what
Correct.
we tell them. So along with PEGLAC, we also tell them drink lot of fluid. So
fluids
that, you
and
don't have to be
ORS is
very
a
well.
clever touch, I
I think
think.
ORS is a
yeah.
good
Yes.
idea.
Prabha
And
is
two
ORS is
ORS.
the
Two
nice tip
ORS.
trick she has taught us, Prabha.
yeah.
So what is the
The
Yeah,
Karnataka
thank
trick.
you, ma'am. Thank you, Saldana sir and Shripada madam. Really, it was a very wonderful
Shripada
discussion. It
gone.
will
Where
help our all, youngsters also, and we are very happy to share the knowledge among us. So,
So we just
thank
want
you,
to say
ma'am.
that complication is part of surgery. Don't get
Really,
upset. Don't get upset, but you have to manage them, face them, and I think you will always come out a winner.
yeah. Thank
Yeah,
you.
thank you, ma'am, for having us.
Yeah, thank you,
Thank you
sir.
for
Thank
having
you,
us. Yeah, thank
ma'am.
you so much.
Thank
Yeah.
you, Shripada ma'am. Priscilla?
let's move on to the third session. We have interesting cases on difficult laparoscopic hysterectomy. It's a case-based learning. The first case would be presented by our Dr. Prabha Desai, ma'am.
Yeah. Thank you, Priscilla. Actually, we are getting late. So I'm just sharing my my case. Wait, what is this? Replace current share. I think sir has to stop.
Stop sharing.
Yeah.
You can share, ma'am.
Yeah, yeah, yeah. Uh, this is, think. Yeah. Am I, whether my, this thing is visible?
Yes, ma'am.
Yes,
Yeah, yeah.
yes.
Yes, ma'am.
It on
Visible, ma'am.
slideshow, ma'am.
Actually, right, lot much of discussion has happened about the vaginectomy or TLH and so on. So this was a very interesting case. Here, the lady has presented to this case. I have put forward just how we can prevent the recurrent endometriosis case. If this case would have not done laparoscopically, then we would have definitely encountered with this lady with another surgery of endometriosis. Okay, yeah, we would have diagnosed it in a later stage when she has presented with either vault endometriosis or with recurrence, or she has not relieved with the pain or some other complications. So this case was 40 years old with a history of menorrhagia with severe dysmenorrhea and pelvic pain since
Excuse me.
5. Yeah. Hello.
Slideshow, ma'am.
Hello. Yeah.
Make it slideshow, ma'am.
Oh, okay. Sorry, sorry. Um, now? Yeah.
Yes, ma'am.
Yeah, yeah, yeah. So she was the previous to normal deliveries and having severe dysmenorrhea with with 10 weeks of uterine size with irregular surface on palpation. She was having a tenderness. On ultrasonography, found that there is a bulky uterus with the features of adenomyosis and with a small multiple fibroid-like things. Probably they might be also having a adenomyotic cyst and with the small fibroids. So with because of menorrhagia and severe pain, she was so frustrated. Even on day prior night, she was asking me whether, madam, can you take me as a first case in your surgery OT? Means that much pain she was having and that much of agony she was had. I said, okay, I will do you first case. And as a routine, we have, oh, what has happened to this? Arre, re. Yeah. So this was our intraoperative first. As we have discussed and seen lot much of hysterectomies now in the today's presentation. So as a routine hysterectomy, we started this case. She was a previous, even though previous normal delivery, but tubectomy has been done with open technique and the tube was adherent. So uh, as per protocol, we start again the same as GSS said, we start from the left side. So I started the case from the left side and then actually I finished the left side case. I will just take little fast forward here because time is short for my presentation. So this was actually adenomyosis case. And I usually do complete dissection of one side first. I open the vault and then I go for the opposite side. So here we are dissecting the adherent tube and adenexa. So see, you can make out there are multiple endometriotic nodules in the POD also. Okay. Actually, I decided to do this case laparoscopically because I was finding restricted mobility and pelvic tenderness. So this was a regular hysterectomy actually. So I have completed she was having a previous normal delivery. So there was no difficulty in bladder opening. And as champagne effect and all from lateral approach to medially, we opened the bladder. And even though I was seeing that there are so many of endometriotic nodules everywhere in the POD on the round ligament, on the uterosacral and all. So I followed the sunrise technique. Actually, I don't use any vaginal manipulator, but I use the myoma screw. And I just push the sponge on a holder in the fornix and then open the vault. Okay. After opening the vault on one side, then we will shift to the other side usually. So that is our protocol, so that we are sure we are not damaging anything. Ureter will also fall very away. So on other side, you could see that there are a lot much of endometriotic nodules. You can see here. And the same steps has been done on opposite side and then completed the hysterectomy. So after hysterectomy, that actually if we would have stopped here only, then we would have patient would have been completely recovered from the her symptoms, but she would have come with again pain, okay, after few days. So this is what we found, that there is this is going little fast forward, so I just made another video. So here the main surgery starts actually. After doing hysterectomy, we realize that there is a endometriotic nodule all over the peritoneum. Okay, in the pelvic peritoneum, there was a all over. And this was the ureteric, this was her ureter getting, there was a ureteric nodule. Sorry, I started dissecting the ureter at the pelvic brim, and we could see that there is a large ureteric nodule at the pelvic brim itself. And it was engulfing the, sorry, whether my music is too loud? Hello?
No, madam.
No, ma'am, you can
It's not
continue.
too loud, no? Because I am
No.
finding it very irritant here. So here we have dissected the ureter, and that endometriotic nodule was completely constricting the ureter that level. It was almost 1.5 centimeter nodule. So you can see that chocolate colored fluid came out of that nodule. Here the discussion went that whether you need a glittering substance, really you doesn't need. And in such cases of ureteric implant, ureteric nodules, you have to separate the ureter and then take out the implant endometriotic tissue completely by shaving the ureter actually. You have to literally shave it. And then the further we have done the dissection of the complete peritoneum over the pelvis. As I could not take out each nodule separately, it was advisable to do the complete pelvic peritonectomy. Actually, this nodule has been missed on ultrasonography, and this pelvic this peritoneal endometriosis is very difficult to diagnose on ultrasonography. If this case would not, if we would not have done by laparoscopically, definitely would have missed all those things, and patient they have a recurrent pain, and she would not have been only relieved of menorrhagia, but disease would have persisted, and the ureter may have got kidney. This is on the medial side of the ureter where we are dissecting. As it was very large nodule, we went very slowly and dissected it. I could not use much energy source here. It's very rare to get an endometriotic nodule or the ureter at the pelvic brim. Usually we find these endometriotic nodules of the ureter in the lower part of the uterus, and where usually at the distal part, but here it was at the proximal end and distal part was free. So complete peritonectomy, I proceeded with the complete peritonectomy. You can see here the peritoneum is hanging. So this is it. One side peritonectomy has been completed, and afterward we on the other side there were, as compared to on the right side, left side, left side lesions were less. Still, it was needed a peritonectomy. So first the sigmoid mobilization and all has been completed, and the ureter exposed, and the peritonectomy has been completed on this side also. So here, after doing the peritoneal dissection, over the rectal peritoneum also has been dissected, so that there will not be any recurrence of the wart endometriosis. Actually, wart endometriosis, I used to think that it is rare, but when I went to the literature, there are so many cases has been reported of wart endometriosis presenting with the secondary menorrhagia, even though after hysterectomy. So both the side peritoneum, which was very thickened, and it was inflamed peritoneum totally. So complete peritonectomy has been done, and the peritoneum over the rectal surface in the posterior for this completed. And then we noticed that there is actually one small nick at some of the vessel has happened. We could not make out which vessel it was leaking. So that was little tense. See here, you can see that like pulsatile bleeding was going on, and that was collecting in the pelvis. So it was a bold step to be taken. We could not put a cautery there. I use a 5, if we put the cautery without localizing the proper knowing where it is bleeding. So I have used a 5-0 proline and took a suture. Actually, it was at the endometriotic area from where we have dissected at the pelvic brim. That area was having a small pulsatile bleed. So to my bad luck, I just took the suture, and while tying it had got broken up. So again, I have to take the suture there. And that was second time taking was little actually tense, but luckily I was very lucky so that I have not pierced any major vessel and I could control that bleed. Before this decision of taking the suture, I thought of cauterizing. So I took a superficial cautery, but that bleed has not stopped. So we have to take this decision. Then comes the vault closure. While closing the vault, I have took the uterosacral of this side and the peritoneum, which has actually wide excise over this area. I don't wanted to leave a raw surface here. So I took the just edge of the rectal border and then took along with the raw posterior edge of the vault and sutured. By doing this, we will prevent the adhesion also. And if you take the uterosacral, you will suspend the wall to uterosacral. So both the purposes will be solved. Because of this, bloody surface, usually this vision has become very dark during surgery. And we could not realize that in this case, the light, what was we usually set was very lowly. Light source was having a less than 50% of the light source was used. So we could not get the clear, picture. So for the vault closure, I use number 1 Vicryl, non-barb. It's a regular Vicryl. I usually use a regular Vicryl because sometimes these barbs will cause, mental adhesions and all. And it will take little long time to dissolve. I'm happy with the regular suture. That is number 1 Vicryl. So this was a final picture of that patient. Both the side, this thing has been, peritoneum has been taken out, ureter has been safeguarded, ureter has been checked again, and then peritoneal lavage has been given, and patient was total, that suture site has been checked. That was also fine. And if you needed, we also plighted sometimes if they are hanging to ovaries, we plighted the ovaries to the lateral pelvic wall. So why I just made this video to present is because when I went to so many, when I searched, so that endometriosis, vault endometriosis is not a rare thing nowadays. We get so many vault endometriosis after sometimes open hysterectomy or vaginal hysterectomy, or if you do the only hysterectomy in case of endometriosis, if you don't do a peritoneal clearance or endometriotic clearance. So this is a specimen where this is both the sides peritoneum and the adenomyotic uterus and the tubes. As she was a 40 years old, so this is one of the actually vault endometriosis patient presented with severe menorrhagia, and at the time of when they approached, the HB was 4.9. Okay, so when you see this case, if you would have not done laparoscopically, we would have missed so many things in her. So this was a case. If anybody has any doubt, can ask.
I would like to add a few things, Prabha. The
Yes, sir.
moment your scope went in, no,
Yeah.
on the close to the left round ligament, I could see the endometriotic spots.
Yes, sir.
You
Yes,
can
sir.
you can rerun that it was there. Number two, when endometriosis is basically extrauterine. So
Yeah.
just by doing a hysterectomy and telling that now the pain will disappear
Yeah.
is not acceptable at all.
Correct.
Third, whenever you're operating on a case of suspected endometriosis, be ready to excise a radical clearance of all endometriotic tissue as much as possible. And a pro tip for the people who are beginners who are scared of ureter, tips for dissecting the ureter are that always try to dissect on top of the ureter, not from the sides. Remove on above it so that you will get the plane, and 3D helps you a lot in case you are deciding to do a lot of endometriosis. Then 3D is not a luxury, it is a necessity in those cases. And always try to go to that plane where you find the ureter. See, there will always be a sheath all around the ureter. You have to go, don't think that this much dissection is enough. You have to be reaching that plane where you can see the white ureter there. And be careful while dissection not to injure the mesentery, because the vascularity comes from the ureter, from the mesentery. It carries its own mesentery. So you should be careful that you do not damage the mesentery. These are important things to be taken care of. And peritonectomy, as you said, you did the perfect thing. It is the ideal step. Whenever you are seeing that there are spots, remove all those and the patient will actually be pain-free. And finally, endometriotic tissue can produce their own hormones. So even if you remove the uterus, the nodules will continue to produce the estrogen. The patient will be symptomatic, and the patient will be coming to your OPD, and you will try to shoo them away.
Yes,
And
sir.
which is not right.
Yeah, yeah. Thank you, sir. I think we'll shift to next case presentation with Santosh Rathod. Hello,
Yes, ma'am.
Priscilla.
Yes, thank you, Prabha ma'am, for that extensive case. We'll take up the discussion a little later.
Yeah.
We'll move to the second case. I request Dr. Santosh Rathod sir to please take over.
I will.
Yeah, ma'am, you can stop sharing the screen.
I'll stop.
Am I visible? Like
Yeah,
my
yeah.
slides?
Yes, sir. Yes, sir. Your slides are visible and you're audible also.
So, good evening, everyone. I would like to thank Prabha Desai madam and KIG team for
KIG
Kasuga team, Kasuga and Karnataka IIG team for giving me this opportunity to present cases, some interesting cases. So today I'll be presenting two cases. One is hysterectomy of a ventrofixed uterus, and the other is a hysterectomy in a large uterine specimen. So first and foremost, as every speaker has discussed, that anatomy of uterus, anatomy of the entire pelvis is the most important thing. One, if anybody thinks of doing a pelvic surgery, then this is the most important thing which should be there. After the knowledge of anatomy comes the proper instrumentation, proper imaging system, proper electrocautery system, and all the other things. Then In the anatomy, the main important thing is the vascular anatomy of the uterus. The main arterial supply of the uterus has to be whenever, even if you are asked at night, you should be able to tell it, because if this is there, then we will have a clear picture of the during operating. So why I have chosen ventrofixed uterus is, with increasing cesarean rates, this is expected to be the more common complication. And for prior imaging of the ventrofixed uterus is helpful during surgeries. Proper inspection and then proceed. Energy source, what current we are going to use, how much and how long matters the most. And one most important, which I will call a Dhurandhar step, will be finding the fat planes during dissection. And the best use of 30-degree scope is very much required to navigate the spaces whichever we are dissecting. And the assistant should be capable enough to show in those deeper spaces. So this is the pictorial diagram where you can see the actual ventrofixed uterus, where it will be attached to the anterior abdominal wall. One is at the upper part, that is just below the fundus, and the other attachment is near the bladder, that is the lower, wherever the cesarean area is. So how to go about? So find the fat, which is a very good friend. So this is the case. So whenever we are seeing such case, the first question is how to start and where to start. So here we can say we should never forget to find the basic steps which we are following regularly. Like I separate the anatomical sigmoid colon adhesions first, followed by adnexal structures on both the sides. So here the first step is the dissection, and I am separating the sigmoid colon. This is followed by, you can see the air has already entered inside and is giving a champagne effect. I am utilizing that, and my next step is the cutting of the adnexal structures. Mainly now I am operating on the left side. I am finding the space. Wherever I get a space, I enter inside and separate it. So manual separation without using current will help us to enter into the spaces where air has already entered. This is followed by cutting of the round ligament and making the space more visible and more operable. So here I am separating, and every time I am looking for the other side. Any small vessel bleeding, that I'll take care, because once there is bleeding, I'll lose my planes. I'll lose the vision. Here I can see the fat. So once the fat appears, so I think that I am in a right plane. Then, so what are the advantages of the ventrofixed uterus is for the advantage of traction and counter traction has been discussed in previous surgeries. So here the traction is already there. The ventrofixation is already giving you the traction. So take advantage of that traction and go on dissecting and finding the planes. So what I do is, before releasing the fundal attachment, I usually try to cut all the adnexal structures and make way at least till the uterine artery on one side, and if possible on the other side also. Here, because I am a ipsilateral surgeon, approach on the other side is a little bit difficult. So I plan to go posteriorly, and you can see I am becoming opportunistic here. I got the opportunity to cut the posterior peritoneum and uterosacral ligaments. I'm utilizing that and completely finishing the posterior peritoneal dissection on that side. So once that is done, I'll slowly release the adhesions, dense adhesions, using sharp cutting current, and I'll try to tease if I can get any space over there. So what all can we use to reduce the bleeding in such cases? If there is more bleeding, then we can use vasopressin in the dilution of 20 units in 200 ml or to 300 ml of saline, and we can inject around 5 cc around the area of dissection. So as I am going on that side, cutting the peritoneum, again on that side, my aim will be to follow my own steps. That is, cut the round ligament, cut the tubes, cut the IP ligament, the ovarian area, and make space till the, so whenever I am getting free space, I am entering inside and expanding the space where the air has already entered. And here where the adhesions are dense, I am using the current. We have to be very much specific, and we have to push the uterus down and then use current, because if we don't do like that, sometimes there are chances of injuring the rectus sheath, which will later lead to hernia formation. So this was a very dense adhesion. So I decided to cut more on the uterus. So round ligament on the other side. So once the round ligament is done, further I keep on dissecting. Now I am putting the probes from both the sides to see the approachability, and if my both hands are approaching, then that means the plane is there. See, whenever I am seeing the plane where I can separate it, I am using blunt dissection moves to create the plane. And whenever there is dense adhesions, so here the fat is there, so I am leaving the fat above and creating the plane below. We have to be very careful here below, because the bladder will be pulled up. So whenever there is a chance to separate it by blunt dissection, we have to do it by blunt dissection. So this is how I separated the fundal adhesion. This was followed by the next separation, that is the bladder area at the caesarean scar site. Here also I go fiber by fiber, cut and keep pushing the lower fiber. See, once the plane is there, the push will be very much easy. Now I found the way to cut the adnexal structure on the other side. And this one step I have included because here I was separating the bladder pillars which were a little densely adherent, and there was an inadvertent injury to the descending cervical artery. One thing which we have to keep in mind in the ventrofixed uterus is the cervix will be pulled up and the cervix will be a little longer. So here you can see, so any bleeding, you should not panic. So I had my shearer in hand. I thought of buzzing, but because of the bladder proximity, I went with the Alice grasper. I held the artery, cleared the vision. Then I asked the vaginal manipulator to push up. So I was just assessing where to coagulate. Once he has pushed up, the maximum bleeder was on the upper side. So I directly went on coagulating the, see, I go,
Dr. Santosh,
I coagulate. Yes, ma'am.
Dr. Santosh,
Yes, madam.
can you hear me? I just wanted
Yes.
to know if you had the manipulator in from the beginning and you're using
Yes,
it
yes, ma'am.
now.
It was I usually put manipulator from the beginning.
Okay, and you're using it only now, right?
Yes, yes. And no, the pull was there, but once after the injury, I told him to push it further.
Mm.
So here I just wanted to show this step. So here you can see how I am moving my bipolar step by step below. I go. So I hold, I coagulate a little, and then if the bleeding is there, then I move a little further. Bleeding is there, so I move a little further down. This will avoid direct injury to the bladder. See, once it is done, the pressure is reduced, and then I take care of the uterines.
And also the ureter is also in close proximity.
Ureter was separated. So, and I don't focus on the venous blood flow. I cut the uterine arteries, and then I keep on lateralizing the artery, because there I go flush to the cervix. So whenever there is more bleeding, don't panic, catch hold of the bleeder, and then take time. If you can catch it, then you do it there only, or else you can just dissect the surrounding area and catch the bleeder. This is the vessel on the other side. Uterine on the other side. This was followed by vault and the final picture.
One doubt I have here, Santosh, I must
Yes,
ask
ma'am.
you, because before we do the uterines,
Yes,
all,
ma'am.
have you finished really?
No, not yet. Like, this video is finished.
Acha, okay.
Hmm.
He's presenting
I hope I'm not interrupting, but I wanted clarity at this point.
Yes,
That
ma'am.
before we do uterines,
Yes,
don't
ma'am.
we ensure complete separation of the bladder down? Because that should
Yeah,
be
yeah.
the
Yes, ma'am. Here I had done.
Hmm.
I had separated it completely down.
Acha, acha. I missed that probably. Yeah.
Here.
Madam, it was a descending cervical bleeder.
Okay.
So that's why he has to go too laterally for that bleeding, and here the injury to the lateral part of the bladder and the ureters are more. So,
That I understood. I
ma'am.
understood
So
why
here,
he had to
one
buzz
more
in.
trick is actually if you are this
Here
thing,
in this step you
you
can see,
can take
ma'am.
a suture also.
Mhm. Okay, okay.
In
Yeah,
this step you
that,
can see the bladder is being separated down.
Okay.
yeah. And it is ventrofix, no? So we will not get like when
Proper
you
bladder
separate
plane.
this, proper bladder plates will not be seen. It
See,
will get
here
automatically
almost I am
covered.
reaching almost up to the vessels below.
Got it. This you are repeating the same video?
Yes,
Yes, ma'am.
ma'am.
Repeating.
Thank you.
For the doubt.
Yeah, thank you.
Yes,
Yes.
yes.
No, because I didn't get this step that you really dissected the
Yeah,
bladder.
and the bladder was a little bit
Now
adherent.
it is becoming clear. Yeah.
Yes, ma'am.
Yes.
Here you
The
can see.
cervix.
I
Yes.
think the dense additions only made all the problems.
Yes,
Dense
ma'am.
Yes,
Yes, ma'am.
fixation. Yes, yes.
Here the bladder pillar was a little bit pulled up. There I was dissecting. That time the
That
injury
time you
was.
got the vessel. Yeah, got it.
Yes, ma'am.
Here, if you are this thing, you can take one stitch also. Then
Yes, ma'am. We can take a stitch.
That will be safer if we are worried about energy source then.
So my next video is about the large uterine specimen. Here we have to plan our traction so that the traction will move the specimen to the opposite side and give you space to operate. And good electrosurgical unit is the requirement. Bipolar is a must on table because larger specimens usually have very big vessels, and the balloon on stick type of pattern, which here you can see, the uterus and the stick will be the myoma screw. I have chosen two type of cases where one is with the vaginal manipulator and the other is with the myoma screw. So this was my. Hello everyone. Today I'm demonstrating. So is it audible?
Yeah, yeah.
It was around in a stepwise manner. The round ligament are cauterized and cut first. The round ligament in a step of 20 weeks size. So here you can see I have used the stick to pull the uterus because larger specimens pushing the uterus with the vaginal manipulator is very difficult, and most of the times the specimen will not move too much. Again, I am repeating the same steps every time, cutting the adnexal structure on one side. Then the broad ligament leaves are cut. This is followed by opening the broad ligament, cutting and reaching the posterior area. On the other side, I am doing similar steps. Then the tubes, which is followed by the uterovarian ligament. Being opportunistic has helped here, which means taking care of the pedicles which were visible and approachable. This is followed by the separation of bladder peritoneum and pushing down the bladder. Then the uterine arteries were skeletonized. Because the uterosacral ligament was not approachable, the bladder peritoneum was separated as down as possible, and the uterine arteries were cut and the pedicle was lateralized. I find lateralizing the pedicle very helpful because that makes sure your uterines are completely secured. The most important part which can be injured here is ureter, because the uterosacral ligaments were not cut. Because of the approachability, they were not cut in this video. The pedicle.
But Santosh, can I again say something?
Yes, ma'am.
Yeah,
Yes,
yeah,
ma'am.
ma'am,
Yeah,
please.
many surgeons do not excise the uterosacrals. No, they cut the vault above it, isn't it?
Yes, yes. Like some of them utilize the cuff. They just go they maintain that ring U-shaped U shape of the uterosacral is maintained, and that is stitched to the vault.
Correct.
But because here the posteriorly, it was a posterior fibroid, I could not go posteriorly and operate. So I didn't cut the uterosacral earlier. So once vault is open, then we can just go on cutting the cervico-vaginal junction, which is followed by cutting the anterior vaginal wall and separating the entire specimen at cervical. And most important tip in large sized uterus is do proper coagulation and go slowly step by step, because once there is bleeding, everything will mess up and the vision will not be that clear. The total specimen was 710. It was taken out through isolation technique.
I think.
Thank you. So
Yeah.
these were the
Dr.
two
Sanda,
videos which I wanted to show.
special step for the retrieval of such a large uterus, no?
Vaginal morcellation or
Yeah, Saldana sir has some. He's there. Egbert sir.
Stop sharing
Yeah.
now. So
Yeah, I'm there. I'm there.
Yeah. Do you have some special something you take? You were telling that day you take some T-shaped incision over the wall.
Yeah. So if there is a large
posterior
uterus,
wall.
if there is a large uterus and you want to, and if the vault is very thin, small, especially in previous LSCS and all, when you pull and tugging can, cause wall tears, and suturing that can be horrible. So what we do is we do an inverted T. So we cut the peritoneum, dissect the rectum down, go right down up to the pelvic floor till the denominus fascia, and take a vertical cut on the posterior vagina. So that will increase the size of the vault and it becomes easier. So you don't have too much of tears on the vault, on the vaginal vault. Now, once you do this, very important is suturing. Sometimes, you have to cut low down and, trying to get the to suture the lower end of the T from above becomes little difficult. So what you can do is take 2-3 stitches from below, leave that, then you take that needle inside and then you finish it from above the vertical limb, and then you do the transverse limb like a normal, whatever you normally do. So that's what we do in large size uteruses when we morcellate. We call it the inverted T. Some people do what is called a smiley. They do a smiley posterior, I mean, I think Nikita Theran does what is the smiley posteriorly. But I think this T is quite good. Only thing is you have to know how to get into the right plane and, dissect the rectum little lower down. Otherwise, if you cut, and you might land up getting into the rectum.
That will reduce the posterior vaginal length also, sir.
Yes.
Posterior T cut will reduce the posterior vaginal length, and the speculum will be right at the specimen. And you can
Yes.
just use, as we do in NDVH, as we exteriorize the fibroid first, like that, we can just posteriorly, you can pull up the specimen and
Then you can debulk it. And you can
debulk. Then we can debulk.
Yeah.
And Santosh, you have presented very well, actually, both the
Thank you.
cases.
Thank you.
As usual, you are an excellent surgeon.
Very nice. Very
See,
interesting.
one thing, just know, in ventrofix uteruses, there are actually 6 standard steps. If you start, I follow that. No, that is really wonderful. If you start from the paravesical space,
Yeah, it is
that is
actually
just about
creating.
round ligament. If you start there, then most of the bladder from both the sides will go up.
Yes, ma'am.
And then you create that tunneling, and then go through and through.
Yes,
And then with that,
creation of
the
a.
two advantage, you can push your uterus down, and automatically the bladder, you will get a traction there, and the bladder will become more, more traction, and then
Below.
you can go more.
Yes, ma'am.
These
Actually,
steps were described very well by Dr. Sandesh Kade.
Yeah.
Yes.
It has Sandesh Kade, and some one
Lateral
doctor
space.
has published it in
Lateral space.
journal.
It is actually
Six steps
creation
technique.
of the obliterated paravesical space.
Correct.
But
These are the
sometimes,
avascular spaces in the pelvis. Yeah.
That is
But sometimes it's very difficult to, in these ventrofixed uterus, once in a way, it's little difficult to delineate the bladder. So there is where.
No, that is why in that video I had shown, though it was old, if you take the help of a Myanmar screw, you can just pull it nicely and you will get the plane for the bladder.
And
that
sometimes
will be an added advantage.
even fill the bladder so that you can find the bladder plane.
Yes.
And there is where you can, I think he used the vaginal manipulator beautifully. I mean, when you're lost, just push that cone up, and you can dissect on that. So it gives you a plane. So I think these are something. So basically, you have to, you learn from everybody little. This is for the newcomers. You add that to your surgery to make your surgery safer.
We should create the
every
spaces.
workshop, every video you see, you will pick up something, add it to your surgery, and it will make your surgery safer.
I think
there is one question by
also
Sonia in the chat box. One question about
Prabha,
vasopressin
just wanted to tell our experiences also, like vaginal manipulator in the beginning is something a boon, like unless that we will be so scared to dissect the UV fold or anything by seeing the planes. So manipulator has a big role, especially in the beginning, till we get into the.
Whenever you are unsure of the ureter, just push so nicely that you can maintain sufficient distance from the ureter. So you will be cauterizing at London and the ureter will be in Tokyo.
Yeah. Yes, sir. Very good insights by all. Thank you. I really thank our today's speaker, Dr. Saldana, Dr. GSS Mahapatra sir, Dr. Egbert Saldana sir, and our chairperson madam and Dr. Sripada madam. These all are experienced people, and your experience is more important to teach the newer generations. So thank you for giving your valuable time and sharing your knowledge. Thank you.
Thank you for having us.
Thank you for having us, Dr. Prabha, and always a pleasure.
And one more thing, I just want to say that I'm just entering into IIG, and I have just applied for my IIG managing committee.
All the best.
Yeah. So I'm
all the best, Prabha.
Yeah, thank you, ma'am.
So
voting will start from 1st February. So I just, as this thing I put, because of so many of the seniors were telling that you should come in the IIG.
Yeah.
So please bless me.
I'm sure all your colleagues will vote for you. Yeah.
Yes.
Madam, you also.
If we don't vote for you, we'll be losing such a humble and such a dedicated surgeon among us, from whom, even though we are senior, we keep learning. and the smile and the way you take everybody in the lead. I have seen in many conferences when we are all together. That's definitely all the best for you.
Dr. Prabha,
Thank
see
you,
you in
Shobha.
Calcutta. See you in Calcutta winning the election.
Sure. Oh, hope for best, sir.
There'll be
I will
party
just
in
Hello,
be
Gadag.
Sonia.
available.
We should all go to Gadag to attend the party.
Yes, we should. We are waiting,
No, but I
Pratibha.
just put it. If I
Yeah.
win, I will definitely.
Yes, Prabha.
Good, good,
Definitely.
good.
Thank you,
All
ma'am.
the
Okay
best,
then.
Dr. Prabha.
Thank you, ma'am. Thank you.
Kardantu we can eat. Kardantu,
Sure,
the
ma'am.
best
Sure.
sweet of Gadag. Hello,
And
Sonia.
Yes, madam. Namaste, ma'am.
Okay.
All the best, Dr. Prabha.
thank you,
Yeah.
thank you.
I'd actually put one question in the chat
Yeah,
box.
our
Sorry
question
for
was there. I was trying to tell Prabha actually. Sonia's
Yeah, I had one question because there's a lot of confusion with the dilution of vasopressin.
That's
Just
why
a very
I
simple
had covered
question.
it.
20 in 200, ma'am. 20 in 200.
20 in
Absolutely.
200.
10
Use
in
5.
100, otherwise.
10 in 100, 20 in
10 in
200.
100. 20 in
Yes,
200. Simple.
any difference of
I
opinion with
No.
Dr. Santosh and Dr. G.S.